post-op management and post-op complications. So there will be three speakers. Dr. Prosenjit Basu is a second-year junior resident at MR Bangur Hospital. Dr. Diptiman Nandi is also second-year junior resident at MR Bangur, and Dr. Shayan is a second-year junior resident at IPGM SKM Hospital. So we start with Dr. Prosenjit Basu will speak on general post-op management. Okay, so you see, in all these post-op scenario, there are some general management and there are some specific management of the particular post-op scenario. So, Prosenjit will describe us the
Good morning, our respected faculty members and all participants. I am Dr. Prosenjit Basu and I am going to present immediate post-operative management and monitoring. The immediate post-operative care is the care that the patient received after a surgical procedure. The type of post-operative care that the patient receives depends on the type of surgery as well as the patient history. It often depends upon pain management and wound care. Goal is to prevent, detect, manage complication during post-operative period, to promote healing of the operative site, to return the patient to a state of good health, and to treat pain during post-op periods. Phases: immediate post-anesthetic phase, that is phase 1, intermediate, phase 2, and convalescent after discharge to full recovery. Purpose: to enable a successful and faster recovery of the patient post-operatively, to reduce post-operative mortality rate, to reduce the length of hospital stay of the patient, to provide quality care service, to reduce hospital and patient costs during post-operative periods. There are specialist as a unit for the immediate post-operative care, that is in a post-anesthetic care unit. The post-anesthetic care unit should be soundproof, painted in soft color, isolated. These features will help the patient to reduce anxiety and promote comfort. PSC requirements, some specification is there for PSU. Should be located close to the operating suite, should have 1.5 PSU bed per operating room used, 120 square foot per patient, and minimum 7 feet between beds. PSC requires personals are central nursing station should be there. 1:1 ratio is good, but 1:3 ratio acceptable for busy OTs. PSU requirements equipments are monitors such as ECG, pulse oximeter, ETCO2, BP monitor, temperature, tray with label, emergency drugs, airway maintenance kit, laryngoscope, endotracheal tube, face mask, airway, ambu bag, venturi mask, picothyroidum set, and transport ventilator. Immediate access should be present for clinical labs to EIBG, X-ray, and blood bank. Pipe tin are required for oxygen supply for air and for vacuum for suction. Criteria for shifting from operating room to PSU are: patient is conscious, awake, respond to simple commands, hemodynamically stable, maintain oxygen saturation, clinical evaluation for neuromuscular blockade recovery, and should be normothermic. Phase 1, it is the immediate recovery phase and required intensive nursing care to detect early sign of complication, receive a complete patient record from the operating room, which is to plan post-operative care. It is designed for care of surgical patient immediately after surgery and patient requiring close monitoring. Management is post-operative care unit, accessing the patient, frequent assessment of the patient for oxygen saturation, pulse volume and regularity, depth and nature of respiration, skin color, depth of consciousness. Maintaining a patent airway, to a primary objective are to maintain pulmonary ventilation and to prevent hypoxia and hypercapnia. Provide oxygen and access respiratory rate and depth oxygen saturation. Maintaining cardiovascular stability. Assess the patient mental status, vital sign, cardiac rhythm, skin, temperature, color, urine output, central venous pressure, arterial line, and pulmonary artery pressure. The primary cardiovascular complications include hypotension, shock, hemorrhage, hypotension, and dysrhythmia. Relieving pain and anxiety by giving opioids analgesic, accessing and managing the surgical site. The surgical site is observed for bleeding, type, and integrity of dressing and drain. Assessing and managing gastrointestinal function. Nausea and vomiting are common after anesthesia. Check for peristalsis movement. Assessing and managing voluntary voiding. Urine retention after surgery can occur. Opioid anesthesia interfere with perception of bladder fullness. Encourage activity, early ambulation, reduce the incidence of post-operative complications as atelectasis, pneumonia, gastrointestinal discomfort, and circulatory problem. PSU, the general length of stay in PSU is 1 to 3 hours, will vary dependent upon several factors, such as types of surgery, patient's response to surgery and anesthesia, medical history. Longer stay may be necessary to meet discharge criteria. Criteria depends on where the patient is sent to ward or ICU room. Discharge criteria for PSU. General anesthesia, for general anesthesia, the patient should be awake. For spinal, moving or bend the knees and able to feel legs. Vital signs should be stable, pain controlled, nausea and vomiting controlled if present, body temperature normal, discharge by anesthesia when criteria met. There are two scoring systems for the discharge, LRAT score and post-anesthesia discharge scoring system. LRAT score, simple sum of numerical value assigned to activity, respiration, circulation, consciousness, oxygen saturation. A score of 9 out of 10 shows readiness for discharge. And our post-anesthesia discharge scoring system is modification from the LRAT score. It's also include assessment of pain and nausea, vomiting, and surgical bleeding in addition to vital sign and activity. It has also the same criteria, 9 or 10 shows readiness for discharge. So LRAT scores from 0 to 2, we give activity. For unable to move the extremity 0, moves to extremity 1, moves all extremity voluntary on command 2. For respiration, 0 apneic. For 1 dyspneic or shallow or limited breathing, 2 breathe deeply and coughs freely. For circulation, if BP plus 50 mm of pre-anesthetic level, 0, BP plus 20 to 50 mm of pre-anesthetic level, 1, and BP plus 20 mm of pre-anesthetic level, 2. Consciousness not responding, 0, arousable on calling, 1, fully awake, 2. Oxygen saturation, SpO2 less than 92% with oxygen supplementation, 0. Supplemented oxygen required to maintain saturation above 91, and SpO2 92% on room air is 2. This post-anesthesia discharge scoring system, there's vital sign within 20% of pre-op baseline, 2, within 20 to 40% pre-op baseline, 1, and for more than 40% pre-op baseline is 0. Activity levels TD, gait, no dizziness as pre-operative level. Assistant 1, unable to ambulate, 0. Nausea and vomiting minimal, treated with oral medication, 2. Moderately treated with parenteral medication, 1. Continues after repeated medication, 0. Pain minimal or non-acceptable to patient control with oral medication, 2. If yes, then it is 2, and no, 1. Surgical bleeding minimal, no dressing change required, 2. Moderate up to 2 dressing changes, 1. Severe 3 or more dressing changes, 0. Intermediate post-op period phase 2 starts with recovery from anesthesia and lasts for the rest of the hospital stay. This includes care of the wound. Epithelialization takes 48 hours. Dressing should be removed 3 to 4 days after operation. Soaked dressing change earlier. Symptom and sign of infection should be looked for, which if present as stitches removed, and daily dressing and swab should be sent for culture sensitivity. Tensile strength of one minimum during first 5 days, then it gains rapidly between 15 to 20 days. Management of drains. To drain fluids accumulating after surgery, blood or pus should come out through separate incision to minimize risk of wound infection. Types of drains are suctions, ADK, CRT. Soft drains form, for example, Penrose should not be left more than 40 days because it form a tract and act as a plug. Inspection of color, content, amount, consistency should be done for the drain. Notify if there is excessive or abnormal drainage. Should be removed as long as no function. Post of pulmonary care. Functional residual capacity and vital capacity decreases after major intra-abdominal surgery down to 40% of pre-op value. Post anesthesia pulmonary edema accentuated by obesity, heavy smoking, or pre-existing lung disease, especially in elderly. Post-op atelectasis enhanced by shallow breathing, pain, obesity, and abdominal distension due to restriction of diaphragmatic movement. Post-op chest physiotherapy, especially deep inspiration, helps this, and we should also add on incentive spirometry. Periodic hyperinflation using spirometer. Adequate management of fluid helps to reduce pulmonary edema. Post-op fluid and electrolyte consideration should be for maintenance requirement. Extra needs resulting from systemic factor, for example, fever, diarrhea, and vomiting, etc. Losses from drainage and fistula also be calculated. And the third space loss. The daily maintenance requirement in adult for sensible and insensible loss are 1500 to 2500 ml depending on age, sex, weight, and body surface area. 5% dextrose with normal saline or with lactated Ringer solution is suitable for most patients. Post-op care of GIT, nothing per oral until peristalsis return. Auscultate for bowel sound, gradual return of oral feeding from liquid to normal diet. Nasogastric tube is necessary after esophageal and gastric surgery. Early ambulation and repositioning help in passage of flatus. Stomach care, look for color, pink or dusky, functionality, prolapse, retraction, and excoriation. Post-operative pain factor affecting severity, duration of factors affecting severity are duration of surgery, degree of operative trauma, type of incision, magnitude of intraoperative retraction, factor related to patient anxiety, fear, or culture. Complication of pains are causes vasospasm, which leads to hypertension, nausea, vomiting, may cause CVA, myocardial infarction, or bleeding. Management of pain are reassurant analgesic, parenteral efforts, anxiolytic, epidural analgesia may be tried, or suppository like Tylenol may be used, or nerve block. Urinary assessment, urine examine for color, amount, consistency, assess indwelling catheter for potency. Urine output should be at least 0.5 ml per kg per hour. Ideally, it should be 1 ml per kg per hour. Phase 3 are convalescent phase. This phase focus on preparing the patient and family for care in the home or an extended care environment. Education and encourage for early mobilization, deep breathing and coughing. Active daily exercise, joint range of motion, muscular strengthening, make walking aids available. Ensure adequate nutrition, prevent skin breakdown and pressure sore, turn the patient frequently to keep urine and feces off screen, provide adequate pain control and follow-up.
Okay, you have given a comprehensive description of different post-op care. The important part of this was your most important part of this post-op care was monitoring, yes, and management of few important aspects. Like you said, fluid, yes, pain control. Yes. When you consider fluid management in the immediate post-op period, what are the things you look for? You are in PACU, and here you have to decide about the fluid management for next maybe 24 hours. What are the things you consider? You have described few points, but few are left.
Sir, vitals should be
before vitals. You have to see the anesthetic note. Maybe the patient was operated for about 1 or 2 hours.
Yes.
What fluid anesthesia is given, number one. What amount of blood loss or evaporative loss the anesthesia assist. Yes. And whether the anesthetist is happy at the end of operation that anesthesia has replaced the volume loss during the operation. Yes. And what are the vitals at the end of operation? If the adequate fluid replacement has been done intra-op, patient vitals will be stable. If the catheter is on, you can assess the urinary output. What should the optimal urinary output?
Sir, more than 1 ml per kg per hour.
Not more than
Even
1
1
ml
to
per
1,
kg
1
per hour
ml
is
per
a adequate output where you can be happy that yes, patient is adequately hydrated. So if you consider that patient intrafluid has been replaced,
Yes.
then as you mentioned, what are the things you consider for planning your fluid treatment for the next 24 hours? You already described. Just repeat this.
Sir,
I assume that the lost introp has been replaced by the anesthetic. Now you are in the PACU and you are going to plan fluid for the next 24 hours. How? You have described. Just give us the salient points.
sir, maintenance fluid
Maintenance fluid. Yes, number one.
and insensible loss.
And maintenance fluid also includes the insensible loss and the
Insensible.
visual output.
Yes,
And
sir.
in the operative scenario, that depends on type of operation. Suppose you have done a hernia operation.
Hernia. Yes, sir.
This
The
patient
minimal
does not have
loss.
an extra loss.
Yes, sir.
You have done a major retroperineal dissection. So this patient have some loss in the drain, some loss in the Riles tube. Okay.
Yes.
So what happens in the immediate post-op period? When you plan fluid in the immediate post-op period, there are some considerations. There are some bodily changes. What happens? What bodily changes occur in immediate post-op period? That will also affect your fluid management. This needs to be emphasized because a lot of people have wrong notion about giving IV fluid. A lot of people give normal saline for next 24 hours. What is required in immediate post-op period? One thing you should keep in mind that in the immediate post-op period, all hormones in the body are increased except insulin.
Yes.
So the net effect of increase of all the hormones, including aldosterone, is there is some amount of retention of fluid in the body, in the kidney, yes, the retention of sodium, and some loss of potassium. So whatever you are calculating as a maintenance, you can be little towards the lesser side because of the hormonal response, there is some fluid retention in the body. There is some sodium retention in the body. Number one. So that is the first consideration you keep in mind. Second is, this patient is kept fasting for next maybe 24 48 hours. Yes. This patient who are fasting needs calorie for basic metabolic functions. What are the basic metabolic functions? Patient in the immediate post-op recovery phase, what are the basic metabolic functions that keep on going? One is brain function, cardiac function, respiratory function, kidney function. Yes. So these are four basic functions which keep on going. And what is the average calorie required to maintain this basic function? Maybe a 60 kg adult person needs, the calculation is about, this patient needs about 400 kilocalorie of energy for maintaining basic function. So one should not think of not giving dextrose in the immediate post-op period. So how much dextrose you need to give for getting 400 kilocalorie? 500. 500. 4 kilocalorie from 1 gram of dextrose. Yes. So you should keep in mind that in the immediate post-op period, next 24 hours, you have to give the patient 100 grams of dextrose. That is the first one. Second is, as I said, you need to give the patient sodium. Do you need to give the patient potassium in the immediate post-op period? No, sir. Why not? There is some loss of potassium in urine because of the hormonal response. But we don't need to give potassium for about 24 to 48 hours. Why it is not required?
Sir, there is lysis of the cells and the
as you operate, you diathermy, you cut through tissues, you suture, there is a lot of cell deaths. Yes. And this cell death releases potassium in circulation. Yes. So immediate post-op period, unless the patient is in a deficit, it did not replace the patient potassium. But one should keep in mind that the sodium calculation, what is the sodium requirement for a maintenance fluid for a 60 kg adult? How do you calculate? Sodium requirement is 2 millimole per kg per day. So if it is a 60 kg gentleman, you will require 120 sodium. But as I said, that there is some hormonal response in the post-op period, there is some retention of sodium. So you can give little less than the maintenance fluid. Again, that will be dictated by the patient parameters. So don't pump more of sodium. What is the harm? Suppose by mistake you give the patient, suppose this patient require about 100 millimole of sodium in next 24 hours. How much a normal saline bottle contains?
So 136.
No, normal saline bottle. Normal saline bottle 154 millimole of sodium and 154 chloride. So if you give the patient 500 ml, you are getting 75 millimole of sodium. In ringer solution, you have 130 sodium. So if you consider giving 1 liter of ringer solution, you get 130 sodium. Suppose you are giving the patient 5 bottles of normal saline. What is the harm? If you give the patient 100 more than this requirement of sodium, what is the ill effect?
So hypernatremia.
What will happen?
So
if you give the patient more sodium, what is going to happen?
So third space loss.
Third space loss, what is going to happen? If you give the patient more amount of sodium, what happens in circulation? What happens in circulation? There will be hypernatremia.
Hypernatremia.
So what happens to sodium in the capillary bed? This sodium will leak in the capillary bed. So what happens in interstitial tissue? It becomes hyperosmotic. It draw water.
Yes.
So if you give the patient more of sodium, there will be interstitial edema. So one should not give the patient a lot of sodium in the post-op period.
So that leads to third space loss, interstitial edema.
Third space loss, third space loss you describe as loss in the retroperitoneum. This is it's not loss. It's a question of tissue edema when there is imbibition of fluid into the third space. Loss cannot. It is sequestration of fluid in the third space, not loss. Okay, so you should keep in mind the fluid management in the post-op period. Second, you talk of pain. You have given everything, but what is the usual ladder for giving pain relief in the post-op period? You have mentioned everything. Suppose patient has underwent a very major cervical operation. What should be the usual measure to relieve pain? A whipple operation is a long operation, long incision, lot of dissection.
Coding system is there.
What? You see, you have mentioned, go to that slide, pain management. Next. Next. So as you have gone to this, if it's a major surgery, your epidural analgesia comes first.
Yes.
That means most of the time the anesthesia should leave me an epidural catheter. So you have to top up the epidural catheter. Epidural catheter pain relief is better because the side effects are much less.
Yes.
Apart from this, you have not mentioned about the drugs. How do you escalate? Will you start giving opioid analgesic at the beginning?
No, sir. We start from NSAID or
before NSAID, it should be paracetamol.
Paracetamol. Yes.
You start in paracetamol and then you can go to NSAID and then opioids.
Yes.
Okay. And for monitoring, you have mentioned everything, but I would have expected that you make a separate slide for immediate post-op monitoring. You monitor the vitals, you monitor the oxygen saturation, you monitor pain. Okay, so you have mentioned about the scoring. Okay. So, okay. Thank you. Next presenter will be Dr. Diptiman Nandi, who will speak on post-op complications and management. Okay.
Good morning, my respected teachers and dear colleagues. I am Dr. Dutta Nandi, second year PGT, MR Hospital. I am going to present general postoperative complications. Postoperative complications are an important cause of morbidity, mortality, extended hospital stay, and increased costs. Early identification of risk allows for targeted, appropriate, anticipatory, and supportive medical care, which will reduce both the incidence and severity of such complications when they occur. Classification of postoperative complications. There are three common approaches for the classification of postoperative complications of surgery. Number one, linked to time after surgery, immediate within 6 hours of procedure, early 6 to 72 hours, late greater than 72 hours. Number two, generic and surgery specific. Number three, Clavier and Dindo. This system relates to surgical complications only and is used to objectively and reproducibly measure the impact of the surgical complication on the outcome of the procedure. General postoperative complications. Number one comes bleeding. Postoperative hemorrhage is most common in the immediate postoperative period, caused by arterial or venous leak, but also by generalized ooze or coagulopathy. Slow bleeds may undergo undetected for hours and patient suddenly decompensates. All patients must have their vital signs like pulse, blood pressure, oximetry, if available, and urine output monitored regularly. Dressings and drains should be inspected regularly in the first 24 hours after surgery. If hemorrhage is suspected, blood samples should be taken for a full blood count, coagulation profile, and cross-match. A large bore intravenous cannula should be applied and fluid resuscitation should be commenced. If source of bleeding is in doubt and the patient is stable, an USG or a CT scan may be required to determine the nature of bleed, most commonly if a hematoma is suspected. If the patient's cardiovascular system is unstable or compromised in any way, for example, neck hematoma or bleeding tonsil, they should be taken back to the operating theater immediately. The treatment of hemorrhage is both to stop the bleeding and supportive. Supportive treatment includes oxygen and fluid resuscitation. It may require correction of coagulopathy. All patients will require close observation. Blood transfusion itself carries some risks like acute hemolytic transfusion reaction, sensitization, fluid overload, hyperkalemia, and transfusion-related lung injury and transmission of bloodborne infections. So the decision about when to transfuse should be based on the individual patient. The consultant surgeon, anesthetist, and hematologist should all be involved early in the care of unstable patients. Next comes deep vein thrombosis. DVT is a well-known and when complicated by pulmonary embolus, potentially fatal, is a fatal complication of surgery. Symptoms and signs of DVT include calf pain, swelling, warmth, redness, and engorged veins. However, most will show no physical signs. On palpation, the muscle may be tender and there may be a positive human signs, which is a calf pain on dorsiflexion of foot, but this test is neither sensitive nor specific. Duplex Doppler ultrasound scan and venography can be used to assess flow and the presence of a thrombus. Other investigations include D-dimer. If a significant DVT is found, one that extends above the knee, treatment with parenteral anticoagulation initially followed by longer-term warfarin. In some patients with a large DVT, a cable filter may be required to decrease the possibility of a pulmonary embolism. Next complication comes pulmonary embolus. Pulmonary embolism is not usually an immediate complication, but can present in the early postoperative period. Thrombus can arise from DVT in the legs or pelvis, vena cava, or the right atrium. Signs and symptoms depend on the size of the embolus and may range from dyspnea, cough, and pleuritic chest pain to sudden severe cardiovascular collapse. Diagnosis of PE begins with history, including risk factors and recent surgery and physical examination, which may include signs of DVT. Investigations may include, depending on the presentation, like ECG, chest radiograph, blast tests like AVG and D-dimer, radiological tests, usually CT pulmonary angiography. If the presentation includes cardiovascular collapse, resuscitation will be needed. Thrombolysis can be considered with massive PE causing cardiovascular collapse. The patient may need inotrops and admission to the ICU. In less severe cases of PE, supportive measures include oxygenation and analgesia. After initial resuscitation, the patient will need anticoagulation, initially parenteral anticoagulation, followed by longer-term oral anticoagulation. Next complication is fever. About 40% of patients develop pyrexia after major surgery. However, in most cases, no cause is found. The inflammatory response to surgical trauma may manifest itself as fever, so pyrexia does not necessarily imply sepsis. However, in all patients with pyrexia, a focus of infection should be sought. The causes of a rest temperature postoperatively include atelectasis of the lung, superficial and deep wound infection, chest infection, UTI, and thrombophlebitis, wound infection, anastomotic leakage, intracavitary collections, and abscesses. The possible causes of pyrexia of a non-infective origin include DVT, transfusion reactions, wound hematomas, atelectasis, drug reactions. Patients with a persistent pyrexia need a thorough review. Relevant investigation include full blood count, urine cultures, sputum microscopy, and blood cultures. Next, general postoperative complication is wound dehiscence. It is a disruption of any or all the layers in a wound. Dehiscence may occur in up to 3% of abdominal wounds and is very discretionary to the patient. Wound dehiscence most commonly occurs from the 5th to the 8th postoperative day when the strength of the wound is at its weakest. It may herald an underlying abscess and usually presents with a serosanguinous discharge. The patient may have felt a popping sensation during staining or coughing. Most patients will need to return to the operating theatre for resuturing. In some patients, it may be appropriate to leave the wound open and treat with dressings or vac therapy. Risk factors in wound dehiscence include generalized factors like malnourishment, diabetes, obesity, renal failure, jaundice, sepsis, cancer, treatment with steroids. And local factors include inadequate or poor closure of wound, poor local wound healing, example because of infection, hematoma, or seroma, increase intra-abdominal pressure. Next complication is pressure sores. Patients undergoing surgery for a prolonged period of time are vulnerable to the development of pressure sore or to a worsening of a pre-existing sore. Careful positioning and padding of the patient is standard practice intraoperatively to reduce risk. Pressure sores occur as a result of friction or persistent pressure on soft tissues. They particularly affect the pressure points of a recumbent patient, including sacrum, greater trochanter, and heels. These factors are poor nutritional status, dehydration and lack of mobility, and nerve block anesthesia technique. Early mobilization prevents pressure sores. High-risk patients may be nursed on air mattresses, which automatically release the pressure areas. Next, a very common post-op complication is nausea and vomiting. Post-operative nausea and vomiting are unpleasant stay for patients, can delay recovery and prolong length of stay. They can lead to more serious complications, including aspiration, pneumonia, precipitation of bleeding, and dehiscence of wounds by dislodging the clots and bursting suture lines. In neurosurgical patients, postoperative nausea and vomiting may precipitate raised ICP with disastrous effects. Risk factors include female gender, non-smoking, and a history of postoperative nausea and vomiting, motion sickness, or migraine. Use of volatile anesthetic agents, opiates, and nitrous oxide add to the risk. Duration, type of surgery also affect the incidence of postoperative nausea and vomiting. Treatment includes adequate treatment of pain, anxiety, hypotension, and dehydration. Antiemetics can be administered both prophylactically and for treatment. Multimodal pharmacological approach using drugs like ondansetron, phenothiazines is most effective. Next, postoperative complication is hypothermia and shivering. Anesthesia induces loss of thermoregulatory control, exposure of skin and organs to a cold operating environment, antiseptic skin preparation, and the infusion of cold intravenous fluids or lead to hypothermia. This in turn can lead to shivering with imbalance of oxygen supply and demand, risking cardiac morbidity. It is now expected that temperature is monitored intraoperatively and in the incidence of postoperative hypothermia has decreased significantly as a consequence. Active warming devices should be used to treat hypothermia. This slide is generalized post-operative strategies protocol, how to give enhanced recovery to the post-op patients. A general presentation like early planned physiotherapy and mobilization, early oral hydration and nourishment, opiate-sparing analgesia regimens that include the use of regional blocks, regular NSAIDs, and paracetamol. Discharge planning is started before the patient is admitted to the hospital and involves support from stomach care nurses, physiotherapists, and other community care workers. Early mobilization is encouraged to reduce the risk of DVT, urinary retention, atelectasis, pressure sores, and fecal impact. Thank you, everybody. This is all.
Actually, you have not touched few points. Like when you start describing general complications, the most important first term is the anesthetic complications. There are some situations that there are some anesthetic complaint, like most important is inadequate reversal. So that is managed on table. So there are some anesthetic related complications. Okay. Second is you have some complications which are described. You have described the different entities like pulmonary embolism. But another important complication is the pulmonary complications. So pulmonary complication needs to be described in a separate heading. Like the pulmonary complication include the commonest complication is pulmonary arterial disease.
So that is a specific that is presented by the next person. So very specific.
No, it's not surgery specific. Pulmonary arterial disease is a surgery specific complication. This can happen in any post-op scenario. There was a OSCE slide yesterday. The post-op patient has got a X-ray and then there is a area of opacity. And the question was on that. So pulmonary complication is not specific complication. These are general pulmonary complication because of upper abdominal surgery splintered the diaphragm. Actually, it is the commonest. Only at least is not corrected, patient will have pneumonia. Okay. Then there are some cardiac complications, general cardiac complications. Elderly patient already ischemic heart disease. Because of stress, they may have acute myocardial infarction. Okay. So what you have described each of these heading as post-op complication. But what I'm trying to say is there are some, even a urinary retention is a general complication. Patient undergoing a hernia surgery, patient undergoing some other surgery under spinal stem may have retention. And when you talk of DVT, we have not stratified the patient into different risk groups. You have to predict whether this patient is at a low risk, intermediate, or high risk for DVT. So in that case, the DVT prophylaxis should start pre-op. And you have to take some measures intra-op. If the surgery is prolonged, you can have some intra-op measures like not pressing the cuff. You can use intermittent pneumatic compression. You can use elastic stockinette in the theater during surgery. And then if the patient is very high risk, you have to consider giving the patient LMWH preoperatively. Okay, so what I'm trying to say is you have to, the point was general complications. So it's not what he will speak on a gastric complication. That means complication following gastrectomy, complication following cholecystectomy. These are specific complications. But general complications are the systemic complications which can happen in any operation. Okay, so it should be better as the complication which can happen in any operation, not specific to that particular operation. Okay. Okay. So the next speaker, as you said, the patient has some criteria for discharge from the hospital. You see, in good centers where they are very busy, they don't keep the patient in hospital for more than 24-48 hours. So there are some criteria for discharge a post-op patient from the hospital. What are the three important criteria that patient needs to fulfill before you decide the patient be discharged now?
So vital parameters are.
Vital has to be there. More three important criteria described in ERAS protocol. Number one, patient should be taking oral feed. You discharge the patient. Patient at home on IV fluid is difficult to manage. So patient should be taking oral fluid. Number one. Patient should be ambulant. That means patient can take care of self. Patient go to the toilet. Patient should be ambulant. And number three, patient should be pain-free. So if you are asked of the criteria for discharge from the hospital, here are the three important criteria. One is patient should be off IV fluid, should be taking oral feed, patient should be ambulant, and patient should be pain-free. Okay. So Dr. Shayan Moral is a second-year junior resident at IPGM and SKM Hospital. We speak on surgery-specific complication. That means complication pertaining to particular surgical intervention. Dr. Shayan, you can share your screen and present.
Hello.
Yes, just a little louder.
Good morning, sir. I am Shayan Moral, first year resident of IPGM, general surgery. So my topic is surgery specific complications regarding general surgery.
Make it slide view. Make it slide view, full screen. Lower part of the screen. Yes. Next. Yes, this one.
First, I'll start with breast surgeries. So the main complications are seroma formation, hematoma formation, infection, incomplete excision. There can be poor cosmetic results, frozen shoulder, lymphedema, flap necrosis, and chronic pain. So for seroma formation, basically it's a small fluid collection which can develop in the brain and the breast after surgery. Draining is the common management which we do. For hematoma also, if it is a very large hematoma, then evacuation is required. Otherwise, it resolves on its own. For lymphedema, like arm exercises are advised to the patient. Also, it is advised to not measure DP in the affected arm, and no IV fluid should be run through the affected arm where there's lymphedema. For any kind of any nerve pain, the pain heals on its own. And for frozen shoulder, exercises are advised to the patient to be done regularly post-operatively. And regarding cording or any axillary web syndrome, the patient is advised physiotherapy and massage so that the cording or the web syndrome resolves gradually. Next, we go for thyroid surgeries. So the most common complication which we come across is hemorrhage. And hemorrhage, their neck hematomas or any kind of large blood accumulation can occur, which can present with pain or swelling with pressure symptoms. They mostly develop within the first 24 hours of surgery, especially the first 6 hours. If it is of very large size, then it may need evacuation. Another complication is hypocalcemia. So if serum calcium is less than around 8 milligram per deciliter, then we consider it as hypocalcemia. Various studies say to measure calcium on POD3. Some says on POD2, but mostly we monitor it on POD3 for hypocalcemia. And for management, tablet calcium and vitamin D can be given for around 10 days for the management. Regarding airway obstruction, there can be a compressing hematoma or some laryngeal edema postoperatively in the patient. If there's a very large hematoma, then opening of the surgical incision can be done to evacuate the hematoma. And as a life-saving measure, re-intubation may be done to save the patient's life. Then there's complication of recurrent laryngeal nerve injury. So if there's a unilateral injury, there can be hoarseness.
You're not audible.
Hello?
Yes, please.
Yes, yes. For recurrent, there can be complication of recurrent laryngeal nerve injury. Recurrent laryngeal nerves, they basically control the adductors of the vocal cord. Most commonly, there's unilateral injury, and it leads to hoarseness of the voice. And there can be superior laryngeal nerve injury, which most commonly goes unnoticed in the patient. Next, we go for parotid surgeries. So in parotid surgeries, the most common complication which we face is facial nerve injury. It can be transient or permanent. We can manage the facial nerve injury by asking the patient to do facial exercises, and also corticosteroid can be given to the patient as a mode of management. Also, there's a Fraze syndrome, which is basically sweating and flushing of the facial skin in an area over the parotid gland, which occurs during meals. In the patient, management can be done by giving botulinum toxin injections to the patient. Next comes parotid fistula or salivary fistula, which is basically a communication which is formed between skin and salivary duct, through which saliva is discharged. It's usually self-limiting in nature. Then there can be a keloid scar, a keloid scar which can occur near the sternal region, and any immediate management is not required for that. Also, there's trismus, which is related to inflammation and fibrosis of the masseter muscle. For management, we can ask the patient to do jaw opening surgeries. So then we come for gastrectomy. So the most common complications are dumping syndrome, which is basically when large amount of water around 1.5 to 2 liter enters the small intestine, it can lead to fall in BP or fainting or sweating or palpitation. And there's nausea, vomiting, indigestion also associated with it. Another complication which we face is acid reflux and diarrhea and anastomotic leak. For any kind of anastomotic leak, we have to monitor the vitals of the patient and see whether there's any kind of tachycardia or any other features of sepsis. If there's any significant features, then we have to re-explore and correct the defect. There can be vitamin deficiencies in the patient, and also there can be ileus. For ileus, we have to manage conservatively first with adequate fluids, and if required, decompression can be done in the management. Then we come for hepatobiliary surgeries, where there can be bile duct injuries. Mostly these are managed by giving a T-tube in the patient. Also, there can be ischemic injury due to devascularization of CVD. There can be some liver lacerations, which if they are not significant in nature, then they tend to stop, and tranexamic acid can be used as a management to control the bleeding. And there can be some bowel injury during surgeries, which can present later. So for that, re-exploration and repair of the defect can be done. Next, we come for hernia surgeries. There's seroma formation which tend to occur out there because of foreign body reactions. So aspiration should be done if it is symptomatic in nature. There can be urinary retention in these patients, neuralgia, neuropathic pain. Neuropathic pain mainly occurs due to damage in the ilioinguinal, iliohypogastric, or genitofemoral nerves, and no specific management is required as such. There can be testicular swelling in the patients, and there can be mesh infection associated with the mesh which is being put in the patient. So if the mesh infection persists for a long time, and if there's a persistence of infection, then on a later date, the mesh can be taken out if the infection persists. There can be recurrence, which is seen sometimes post surgery, the recurrence of hernia, and also there can be mesh migration. Also, there can be osteitis pubis, which is basically when a suture is taken through the periosteum, and for that, anti-inflammatory drugs, physiotherapy, or any corticosteroid can be given to the patient. Next, we come for appendectomy, where the most common complications are infection, pyrexia, ileus. There can be reactionary hemorrhage, and there can be stump appendicitis. There can be fecal fistula, and there can also be some bowel perforation, which presents at a later date. Then we go for stoma surgeries. We tend to find skin irritation around the stoma site which occurs. There can be high output stoma, especially in ileostomy. Uh, there adequate fluid resuscitation needs to be done in these patients. There can be a necrosis of bowel. So for that, we have to refashion the stoma, and for any kind of parastromal abscess, we have to monitor the vitals, and if it persists, then evacuation of the abscess will be needed. There can be stoma prolapse, which can occur at a later date after the surgery, and if it leads to any obstructive features, then the stoma needs to be refashioned, and there can be stricture in the stoma. This mostly occurs as a late presentation in stoma surgeries. So for exploratory laparotomies, the most common complications are paralytic ileus. There can be anastomotic leak. There can be DVT and pulmonary embolism. So for DVT and pulmonary embolism, if the patient's features are poor from the beginning, then preoperatively measures can be started. Otherwise, postoperatively, we can manage the patients with medication, as well as stockings can be advised for the patient. There can be wound infection. There can be obstructive features in the present patient post-surgery. There can be some injury to bowel or ureter, and there can be anastomotic stenosis, which might present as obstructive features on a later date. Then comes orchidectomy. So for orchidectomy, there can be presence of scrotal hematoma in the patient. We can keep a CRS drain in place during surgery so that the hematoma can be evacuated. There can be presence of a local infection in the patient, so patient is told to maintain proper hygiene. And there can be infertility, there can be a loss of sensation overlying the scrotum. Uh, Next is for amputation surgery. So there can be presence of hemorrhage in the patient and skin necrosis or the flap necrosis where the sutures are being made. So the site should be monitored properly, and if there's presence of ascending necrosis, then the site should be refashioned. There can be hematoma, there can be DVT, and phantom pain can occur. So for phantom pain, antipsychotic drugs can be suggested to the patient. And for flexion contraction of proximal joint, physiotherapy is advised to the patient as a mode of management. Thank you.
Sayon, actually, you have taken the huge number of topics for the discussion, covered well, but what I would have suggested is you have taken, go back to thyroid, breast first.
Yes, sir.
You said seroma. Yes, seroma is the on treatment component, but you see, most of the seroma does not require drainage.
Yes, sir.
If at all, this seroma can be repeatedly aspirated.
Yes, sir.
And as you go to this, all these complications, now for each of these, it would have been better that you have an idea that there are some complications which come in the immediate post-op period.
Yes.
There are some intermediate complications and delayed complications. So the complications should have been on this order for the immediate complication, and you have to address that. Okay. As you come to thyroid, you just come to next thyroid. Yes. You see, in the immediate post-op period, before hypocalcemia, our concern is airway obstruction.
Yes.
Bilateral legal palsy. Okay. And hypocalcemia, you said you do the fast estimation third day. Third day may be too late.
Okay.
Patient, you have to keep in mind that patient who already has a calcium level to the lower side may manifest hypocalcemia in the immediate post-op period.
Yes.
How will you diagnose? How clinically you will diagnose that patient has got hypocalcemia?
Sir, we will check for
what symptom patient may have. What
okay.
symptom patient may have?
Tingling and numbness.
Yes, patient may have perioral tingling and numbness.
Yes.
And there are some signs you can elicit which can suggest that hypocalcemia. And then do the calcium estimation. And more importantly, you should have an idea about the ionized calcium level, which is more specific to predict hypocalcemia. Okay. And if the patient has got bilateral legal palsy and airway obstruction, what is the management? In the immediate post-op period, you find that patient has got severe respiratory distress, and on table you have demonstrated legal nerve was all right, but probably patient has a transient palsy and severe respiratory distress. What is the management?
Sir, we will have to create an alternative way for respiration, like intubation or.
Okay, so you can try intubation, but sometimes intubation, if the cord came to pyramidian level, intubation may be difficult. Okay. In that case, as a life-saving, you can do a cricothyrotomy or do a tracheostomy. Okay. And as you come to the parotid, next parotid, yes. You see, facial nerve injury. Yesterday there was a question. Yesterday in OSCE, in ANB, there was a question. They have shown the picture of facial nerve, and there was a question that of these branches, which branch injury may go unnoticed and may not cause any symptoms? You know? Yeah, wait, cancer. They said that out of these branches, one branch injury may go unnoticed. Was clear? No, posterior don't find in the operation field. This is the cervical branch. Injury to the platysma, branch to the platysma may go unnoticed. And as you said, this facial nerve injury, if you have a situation that is got a transient injury, in that case, there is a role for giving the patient steroid also. Okay. And Fraze syndrome, there are a number of, apart from botulinum toxin, there are a number of other measures you can take for manage this. And a gastrectomy is a big area. You see, gastrectomy and vagotomy has got a lot of complications. You see, in that case, there are early complications, delayed complications. Okay, so there are a lot of other things need to be discussed in this. Actually, you have taken the whole lot for discussion. That's why it become a little brief. Then come to biliary surgery. I would have preferred that you describe the important complications of lap cholecystectomy. You see, so maybe open or lap, whatever, but lap cholecystectomy should have been come in a better way. That you see, lap cholecystectomy has got some complication because of access complications. While you're taking access either by a varus or a open port, there are some complications. Second is there are some complications pertaining to the gallbladder itself, like bile duct injury, vascular injury. Okay, so these are the specific complications related to the gallbladder surgery. And next, come to stoma. Yeah, stoma again is a surgery where there are a lot of complications which can happen in immediate post-op period. It may be haphazard. Immediate post-op may be number one, stomal necrosis, ischemia, stomal retraction, stomal prolapse. Okay, these are the immediate post-op complications. Subsequently, you mentioned about the parastomal abscess. Parastomal abscess is not very common. More common is parastomal hernias. Okay, and then delayed you may have stricture, yes. And come to exploratory laparotomy. Why in exploratory laparotomy you should have a ureteric injury? You see, exploratory laparotomy is not a specific operation. Yes, to understand. Exploratory laparotomy is not a specific operation. So we are describing the specific operation. Exploratory laparotomy can be done for various reasons. Yes. So your complications like exploratory laparotomy will depend on what is the primary surgery you are doing. Yes. If you are doing exploratory laparotomy, there is no reason you will injure the ureter. You will not go to the posterior abdominal wall. Why should you go? So exploratory laparotomy as such is not a defined operation. It's an operation to explore the abdomen to find a pathology. Yes. So in that case, it will be all your own related complication and the complication for the particular specific procedure you have done. Yes. Okay. So you have covered a lot of things, but what I'm trying to say is make it a more comprehensive in the form of early complications, and these are complications, and these are the measures to address that complication. Yes. Okay. Yes. Thank you. Any comments from anyone? Chat box, we've answered that. Yes. You see, liver, not only liver failure, in hepatobiliary, we have not gone to the Whipple's operation. If say Whipple's operation, you have the complications of hepatorenal syndrome, you have the complications of pancreatic fistula. So it's not possible to discuss all the operations specifically and come to all the complications, but here's the main part. But again, if you take Whipple's, Whipple has his own complications. If there's no comment, we can close. Okay. Thank you.